Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in to my podcast. As always, please scroll down and you'll see there's a subscription button. Please hit that. Today I have a few things I want to get into. We really are been focusing a lot lately on endometriosis and what it is that we do to help treat that. What natural things can I do? What lab work can I do? How would a prescription affect these patients? How would a natural approach also help these patients? How do I marry these together? The goal of this podcast is to create for you content that's helpful for you. I really want you to have a healthy relationship with your care provider. And I know we don't always have that. And it's important that you develop that relationship. And I think giving you tools to understand what's happening in the background of your health with what we're doing here, it gives you that ability to go to that appointment with your doctor and be able to communicate with them in a way that they would understand and offer ideas yourself that may be helpful to you. So with that said, I'm going to get moving forward, but I want you to know in this podcast, I take this part of my job very seriously. I'm not sponsored by a nutraceutical company. You know, I'm never going to sit here. I'm not going to solicit you to come see me in my practice, but I am looking to be as helpful. What is it about endometriosis that is so difficult for care providers to put their hands on? What is it about endometriosis that it's not really responsive and it doesn't seem to make sense when they provide care for it? What is it? What's that disconnect you're seeing when you have endometriosis? What is it that you're experiencing? Why is that occurring? Well, I want to say this. A lot of it has to do with the type of therapies that they're employing. The therapies you employ to treat endometriosis are largely just very suppressive and very domineering to a system, but they're not nuanced and they're not specific to the individual. You know, and the fact is that when you treat people with endometriosis, if you read the book on my end as the physician, you read the texts around it, you read the standards of care established, they tell you not to run labs. You know that? It tells, lab work doesn't help. Doesn't help. You know, don't do labs. They also mention things like, you know, imaging is limited in benefit. It's really is not. It's because they don't fully spend time to fully understand everything around you. And they advocate for just a suppressive approach. And suppressive approaches work for a percentage of the population. And from a business perspective, if I can help a percentage of the population enough, I'm fine. But that's not medicine. Medicine is you. It's you. You're not a percentage. You're someone's mom. You're someone's daughter. You're someone's wife. You're someone's sister. You're someone's someone. So the first thing about endometriosis is that you deserve us to understand you medically. I mean that deeply. I mean that because none of you get that and you deserve it. It's very rare that women get understood. I'm not implying that I fully understand everything about women. I don't. But I come to that room with curiosity with you. I want to. And I may not get it right every time, but you know I'm there with you. And if it didn't figure out that first time, you know I'm going to go deeper with you, and you and I are going to keep figuring this out till we have it. You deserve that care. So I'm going to start by saying that to you. Let's get a little bit further into this. You know, estrogen dominance is the most important component of endometriosis to talk about. And estrogen dominance is the center point of this. And what is that? In your life, when you're cycling, as I mentioned in previous episodes, and in life, you know this. You know, you have your first half of the cycle, that's going to be estrogen dominant. And you have your second half of the cycle, that's more progesterone dominant. When you don't ovulate, estrogen will be high all month long, and you will have diminished levels of progesterone, and you'll have tissue being overstimulated. That's what estrogen will do. Estrogen will go and will stimulate all those parts of you associated with fertility. So women who don't ovulate, who have estrogen dominance, are going to have, a lot of times they'll have breast pain because that tissue is being over-recruited, or dense breast tissue. Some women are going to have more recruitment of endometrial tissue, so that tissue is becoming a little bit thicker, a little bit heavier, you have heavier periods. Some women will be having weight gain disproportionate to calorie intake because of the impact that estrogen has on adipocytes or fat development in the body. And these are all true. These are all true. Without ovulating, you're going to see more of those components. Further, estrogen is important for brain chemistry, but you need progesterone as well. And so, when women don't ovulate, low progesterone, you'll see an inhibition on their ability to make something called monoamines. And this is very important. Serotonin and then melatonin. Melatonin is part of that pathway. So when you eat food that has tryptophan in it, that food, the tryptophan, it gets in your system, and then tryptophan crosses the blood-brain barrier, turns to 5-hydroxytryptophan. 5-hydroxytryptophan turns to serotonin. Serotonin then goes on a couple more little stops, then it becomes melatonin. So how your body makes serotonin and melatonin starts with tryptophan, and it is strongly influenced by progesterone. If you don't have progesterone, that pathway slows down. And then you're stuck with not enough serotonin, which you know that with women with PMS. Women who have low progesterone, high estrogen dominance, they're going to have PMS symptoms of depression, insomnia, and headaches. These are all things associated with that monoamine pathway being broke down. How does it do anything with endometriosis, Brendan? Good question. When you don't ovulate, there are 2 times in your life you're not going to have really the best ovulation. This is a normal part of life for you, by the way. When you were in the first years after menarche, when you start having your period, the establishing of a normal cycle with adequate progesterone doesn't always happen right away. Often it takes a little while for that to occur. So those first few years of cycling, you're going to see estrogen dominance, and that's going to see all those other symptoms you have at play. And in this case of endometriosis, the lining of the uterus is becoming thicker. This is important. The other time you have it, by the way, is going to be perimenopausal, from your late 30s all the way up to your late 40s. So sometime in that decade, you're going to have more and more instances of this. So why is it then, back to PMS in young women, why is it then that all women who have PMS don't have endometriosis? Good question. There's another factor at play as well. Inflammation in the body is another component. And the final one, the most important one here, is going to be that inhibition of monoamines. Let me do the monoamine first. Melatonin is on that pathway. Melatonin, everyone thinks of it from the pineal gland, the perspective that melatonin plays a role with sleep. And it does. You need melatonin for sleep. Truth. Melatonin, though, is way more than that. And it's not just in the pineal gland, it's throughout your body. So melatonin in a woman's body plays a role as an antioxidant. It's anti-estrogenic. It's anti-inflammatory. I did repeat it there. Anti-estrogenic. So it has these benefits, but there's another receptor component of melatonin that when you're deficient in melatonin, you have a higher rate of migration of endometrial tissue, mitigated by by estradiol, excuse me. So when a woman has lower levels of melatonin, they're going to have a higher instance of that endometrial lining mobilizing and going elsewhere. So when a woman does not have adequate progesterone, she's not cycling in the first years of menstruation, and she doesn't have that monoamine pathway working very well, and she ends up having low melatonin through that, we're going to see in those women more of a migration of that endometrial tissue. So this study here that we're putting up here, this is one of many on the impact melatonin has on migration of endometrial tissue. And this is where they research and discuss how melatonin inhibits 17-beta estradiol-induced migration evasion on epithelial mesenchymal transition in normal and endometrial epithelial cells. A lot of nerd in there, huh? As it is. This is not an article people want to read. This really is a heavy article, but it's an article you need someone to read, and you need that person to read it, understand it, and then be able to sit down with you in a room and explain it to you, because that's why you hire us to be your doctors. Melatonin is an important component of treating endometriosis in the impact that it has on inhibiting that migration of the tissue out of the endometrial lining and going out to different parts of your body and becoming active. This is incredibly important. So the use of melatonin in clinic when it comes to treating endometriosis is a game changer in my experience, and also in the literature. So what it is that causes women in this age group not to ovulate very well? This is another area that we should be aware of and think about when we approach them. A lot of times you guys are not ovulating due to stress, and the world is more stressful every generation, it seems. And I see this clinically in practice. But stress does inhibit ovulation. And think about it. You know, you're having a normal cycle going on, and all of a sudden something stresses you out and you miss your cycle. And how many of you thought you were pregnant when you did that? And that made you even more stressed out, and then you went even further without that. So we know stress really does inhibit ovulation. So this is a part stress may play a role. We also know that sometimes due to diet and also excessive stress, you'll have increases in prolactin. Now, prolactin can still be in the normal range, but if it's the higher end of the normal range, when prolactin is a little bit higher in the normal end of the range, it's still going to inhibit ovulation. So it's important for us to keep an eye on that prolactin and understand why they're not ovulating. Is it due to stress? If it's stress, look at the cortisol. If it's stress and possibly diet, look at that prolactin. What else could be at play? Diet. Diet plays a role with ovulation independently through eating a pro-inflammatory diet, yes, but mostly due to the way that it affects prolactin and ovulation in of itself. So I really always want to look at diet, not just from prolactin, but for inflammation and see if it's a pro-inflammatory diet. Then there's also endocrine disrupting compounds that are in our diets nowadays, and that's going to be a lot of these microplastics you're seeing, and then the downstream metabolites of that and the impact that has on ovulation. All of these things play a role in causing estrogen dominance in you. And that estrogen dominance, again, is the key to starting endometriosis. And the secondary component is going to be how it inhibits monoamines, and it's going to be causing you to have that low melatonin, allowing there to be migration of that tissue. So these are some aspects. And again, this is not, I want you to know this is not exhaustive. There are other components here. There are other things that could be causing this. These are the ones I want to discuss because they rarely get discussed. And these are things that if we can treat these, we can get these into balance, we can have better results when treating endometriosis. I want to leave you with one thing here. I just talked about how ovulation and ovulatory cycles really are the key points to this, and how that affecting that monoamine pathway, which is going to be melatonin, is a key component of this. And I think these things need to be brought up. And I want you to know, in the back of my mind, I'm hearing the questions that a doctor would ask, or even a patient who's been going through this for a while. Why isn't it then that birth control would not work? If birth control is going to help modulate that estrogen dominance, which is what it's supposed to do, and I'm getting a synthetic estrogen and synthetic progesterone from that pill, how is that not solving the problem then? Why? This is key. When you take oral contraceptives, you're going to play a role only in the physiological output of estrogen and progesterone from your ovaries. To the degree those hormones, those synthetics, are going to inhibit your natural production of natural estrogen and natural progesterone. Now, to the degree that these synthetic hormones bind to the receptors in your body, there's that other effect of them, that the other benefit or side effects that you have from them. So synthetic estrogen, does that have benefit to bone density? You have to go down these roads. Why I'm saying this is that when you have synthetic progesterone in your body, synthetic progesterone does have a physiological effect with the uterus, etc. But synthetic progesterone does not cross the blood-brain barrier and have any impact on the monoamine pathway whatsoever. This is why you'll have women taking oral contraceptives, and it will not have a positive impact on brain chemistry. You'll see them actually having a worse effect, because now what little progesterone they're now making none, because you gave them a suppressor. So you only have the synthetic. You don't have any natural. And if you have no progesterone, you're not going to have that benefit of when progesterone crosses the blood-brain barrier, turns to allopregnenolone. Allopregnenolone plays that role with anxiety, depression, insomnia, and sleep, because allopregnenolone helps the production of serotonin and melatonin, and allopregnenolone binds to the GABA receptor, which is the anxiety. So allopregnenolone is a key component of care with endometriosis, and that comes from progesterone. So this is such a critical component, and this is why you see it doesn't always work. And this is why I have a problem with suppressive care long-term. Short-term, stabilize the woman. Yes. Pull out all the stops. Do everything you can. Do no harm, but do literally everything you can to be there for them. That's first step. Second step, How can I solve for X? How do I understand this woman? How do I get under the hood in here and understand them and create a protocol with lasting positive effect? I hope this helps. Your comments help drive this content. If I just said stuff, I said some nerdy stuff a minute ago. If I say stuff that doesn't make sense, if I say stuff that you can't, I'm not here for me. I'm not here to be like, oh, I understand this stuff. Look at me. That's not my goal. I don't like that. I don't even like that. I want to be clever in as much as I'm able to take a complex, nerdy, worded out thing here and make it really understandable without losing the science. I want to use the language that you speak, and I want to speak to you in true, simple, regular, everyday words and convey this complex concept to you because it can be done. And I know I can do it, and I want to do a good job at it. So to the degree I do it, I'm great. To the degree I'm not, your feedback, give it to me. I appreciate this. So tune into the next episode. Please like, share, and subscribe, and I'll see you soon.